Welcome, everyone, and thank you for joining us today. Our presentation today is with Leanne Singer and Ria Varghese. It's called A New Approach to Evaluating Frailty in Solid Organ Transplantation. I can't even say that right today. I just want to go through a few housekeeping items before we start today. We have Amanda Lorbergs, our Manager of Research in KT, who will facilitate the Q&A session. And if you could, please submit your questions online during the presentation, and we'll try to reduce any duplicates and present them at the end of the presentation. And we'll try to answer as many as we can. At the end of the survey, you'll have a survey that will pop up on your screen. And it's just to give us some feedback on how to improve the webinar series. And one of that might be to improve my vocabulary today, because I seem to have had too long a Christmas break. So the webinar slides and the video will be available within about 48 hours. And you can see the URL on the screen if you want to go and hear it again. We have 2 webinars scheduled coming up, Wednesday, January 23rd with James Downer, and he's doing the pilot study of an automated 1-year mortality prediction tool to trigger advanced care planning, and that was part of our Catalyst grant program. And on February 6th, we have Greg Hirsch doing cardiac surgery among the frail and elderly towards optimal decision making, and hope that you will go immediately and sign up for these, because I think both of these will be as good as today's presentation. We do have a KT competition in process. The timelines are unfortunately a little shorter than we wanted, but they are due. The intent to apply on Monday, January 14th. There's the URL if you want to look at more details. And we also have a HQP contest, Frailty Matters. It's a video contest. And we're looking for your experience with somebody who is living or caring for an older adult living with frailty, or family caregivers. There will be prizes to be won, and again, it's only open to our trainees and our alumni, and there's the URL at the bottom of that screen.
I'm sorry, Carol, I can't see your screen. I don't know if others can.
Can you not see our screen?
I can't.
I can.
Okay, so something wrong with my system, sorry.
Okay, we'll double check back here, and if somebody in the audience can't see the screen, can you let us know, maybe using the question, and then we'll be able to fix that at our end. So now I'll introduce the presenters today. Leanne Singer, she's the Associate Professor in the Department of Medicine with cross appointments to the Institute of Medical Science and Health Policy, Management and Evaluation at the University of Toronto. She's Medical Director for the Toronto Lung Transplant Program, staff physician at the University Health Network, and understand that she's on call today and may have to leave at any point, but we hope that doesn't happen today. We also have Ria Varghese, and she is doing most of the presentation today. She's a clinical lecturer in the Department of Medicine at the University of Calgary, a respirologist with the Southern Alberta Lung Transplant Program in Calgary. So over to you, Ria, to start your presentation.
Thanks for the introduction. All right. I'm hoping the slides worked.
I can see those.
Okay, perfect. So, thank you very much for this opportunity. I'm looking forward to talking about our experience in frailty for the solid organ transplant population. Leanne is the primary investigator for this project, and I was the HQP for it when I was doing a research fellowship in Toronto. All right, so we don't have any disclosures except that we're excited to be looking at frailty in this population. And so our objectives today are to review some of the literature about frailty in the solid organ transplant population. We also would like to describe how we developed our cumulative deficits frailty index using a routine transplant candidacy assessment. And then finally, we'd like to talk about the associations with transplant outcomes between frailty and our cumulative deficits index, as well as mortality in our transplant population. So solid organ transplantation's main aim is to improve survival and quality of life in patients who have end-stage organ failure. Unfortunately, this objective is limited by a scarcity of donated organs, and the procedures themselves can be quite stressful physiologically and as well psychologically on many patients. But as we've become more comfortable, we have started to transplant more medically complex and older transplant candidates. If we look back 5 to 10 years, many of the patients that we transplant now wouldn't have been considered because of their age. But now many programs are loosening their restrictions, and we're looking more at the whole patient rather than age alone. So the candidacy evaluation is comprehensive, multidisciplinary, and the aims of the evaluation are to look for disease severity, decide if it's the right time for transplant, optimize comorbidities and socioeconomic factors, and also predict benefit from transplant. We screen for malignancies, we look for different comorbidities. Our social workers typically look for psychological challenges so that we can work on those and help modify people's financial situations so that we don't have challenges after transplant. Once we've gone through the candidacy evaluation, if they meet the criteria for transplantation and we've optimized everything that we can optimize, we list them for transplant. Over time, we have noted that that there is an increasing need for evidence-based candidacy measures instead of a clinical gestalt. We've also noted that the risk prediction models that we're currently using are not perfect, and we are missing something. And frailty may be one of these components that we are missing in our candidacy evaluation. So we know that frailty does matter in transplant. Most of the studies done to date are in the pre-transplant population, and most of them use measures of frailty phenotype, such as the index made by Fried measuring shrinking, exhaustion, low activity, slowness, and weakness, or the short physical performance battery. So we also have used pre-transplant frailty to correlate to post-transplant outcomes. And we do know that mortality and waitlist mortality do correlate with frailty. The importance of frailty has been recognized by our clinical organizations. The American Society of Transplantation, in conjunction with the Canadian Society of Transplantation, had a working group on frailty. So on this working group, we noted that the optimal method for measuring frailty is unclear in the transplant population. And also, we determined that we need to learn how to reverse frailty both pre and post-transplant to improve outcomes. The other thing we wonder is whether transplant itself is an intervention to improve frailty in this population. So frailty matters to transplant programs because we are transplanting sicker patients. Our patients are older than they were, and we are using older and higher risk donors. We also acknowledge that our risk stratification is not the whole story, and that clinical gestalt sometimes is wrong, and that we may actually overestimate someone's frailty by our eyeball test or underestimate the challenges that a patient may have. So looking at pre-heart transplant candidates, this study looked at patients with heart failure that were referred for transplantation. They noted that 33% of their population was considered frail by the frailty phenotype. They also noted that frailty increased with disease severity, marked by the NYHA scale, and you can see this in the bar graph. When they looked at overall survival in these frail patients, the frail patients clearly had increased mortality. They also noted the frail patients having cognitive impairment and worse hemodynamic parameters such as cardiac indices. These findings were independent of age, sex, heart failure duration, left ventricular ejection fraction, and renal function. This is a meta-analysis in heart failure patients showing both multi-dimensional frailty studies, mostly the cumulative deficits index, Tilburg frailty indicator, and a geriatric assessment, as well as physical frailty measures such as the frailty phenotype and the short physical performance battery. They noted that when through all of these analyses, 45% of the subjects with heart failure had frailty, but there was a huge variability in the studies. So frailty is a highly prevalent issue in the population requiring heart transplantation. Sorry, I didn't advance the slide. This is the meta-analysis. And moving to kidney transplantation, this study looked at the frailty phenotype at the time of transplantation in 537 patients. After adjusting for confounders, frail kidney transplant recipients had a 2.2-fold increase in mortality compared to those that were non-frail. If you look at the bar graph, they noted the intermediately frail as a score of 2 by the Fried index, and then the frail were greater than 3. The bar graph shows that the majority of patients were non-frail to intermediately frail, but there are a significant number of patients that were frail that they transplanted. So when we look at the Kaplan-Meier curve, we can see that frailty does have less survival than the non-frail patient, but when we look at the curves, they're actually pretty close together, suggesting that perhaps the intermediately frail and the frail still aren't necessarily negatively affected by transplantation. These frail patients had a 90 to 95% survival at the 1-year mark, which would be considered relatively acceptable in most transplant programs. They did note that frailty and mortality did not differ between older and younger patients. McAdams DeMarco also performed a study looking at whether frailty changes post-renal transplant using the frailty phenotype. She looked at those that were frail at the time of kidney transplant, were twice as likely to have improvement in frailty after transplant, but it took about 3 months to achieve that. She also noted that pre-transplant frailty, diabetes, and delayed graft function were independently associated with long-term changes in frailty scores. Lai is one of the predominant frailty researchers in the liver transplant population. When she looked at approximately 300 patients using the frailty phenotype, she noted that frail patients had higher MELD scores, higher rates of ascites, and more hepatic encephalopathy. She also noted that frailty was relatively prevalent in the liver transplant candidates at approximately 20% of candidates, and that they were more likely to die on the wait list or be delisted due to medical contraindications. She also noted that the MELD sodium, which is a risk prediction model characterizing prognosis for liver transplant for liver patients and is used for listing for liver transplantation, did not adequately predict waitlist death and delisting. She also found that the MELD sodium didn't account for physical frailty, functional decline, and potentially muscle wasting. To try to capture physical frailty, she developed the Liver Frailty Index, which encompasses grip strength, number of chair stands per second, and balance time. With this and the MELD sodium score, she noted that it had better predictive value in waitlist deaths and delisting. She also noted that the Liver Frailty Index improved mortality prediction compared to a subjective clinical assessment by the hepatologist assessing the patient. This study also basically points out some of the limitation of using our clinical gestalt and the importance for us to have a better way of assessing frailty. So in lung transplantation, we also note that frailty is common. In the study by John Singer, he notes that approximately 28% of patients are frail by the frailty phenotype, and 10% are frailed by the physical performance battery. He had 80% overlap in classification of frailty between the two indices. He noted that frailty was associated with increased disability in the pre-transplant population, and that increased frailty meant decreased exercise capacity. So looking at waitlist mortality or delisting for medical contraindication in the lung transplant candidate, frail patients were more likely to be delisted or die. The hazard ratio for waitlist, delisting, or mortality was 1.38 using the frailty phenotype and 2.99 using the physical performance battery once adjusted for age and clinical status. He also looked at it in the post-lung transplant population, looking at their frailty prior to transplant and correlating it with their post-transplant mortality. He notes that there's approximately 10% mortality in those that are frail by both the short physical performance battery and freed frailty phenotype, and that they have associated increased hazard ratios. That said, 1 year mortality of 10% is actually the mortality published by our international registry and is likely acceptable for our population. The challenge is we don't know how to intervene on these patients that we identify as frail prior to their transplant, and which interventions make a difference at this time. Dimitri Rosenberg, who works with our group, also looked at the frailty phenotype in lung transplant patients. Unlike Jonathan Singer's studies, he noted that there was no difference in length of stay in the ICU post-transplant or in hospital, that patients' discharge disposition between home and rehab was not different, and that mortality wasn't different using the frailty phenotype. That said, in the same cohort, Rosenberg noted that quality of life improved in both frail and non-frail patients by the 3 to 6 month mark post-transplant, and the frail group improved more than the non-frail group. So the challenge with most of these studies is, outside of a few, pre-transplant frailty is correlated to post-transplant outcomes. We don't really know whether the interventions of medical care that we provide pre-transplant are making changes to frailty. In addition, we don't know how frailty evolves post-transplant. Another limiter is that most studies in transplantation have used only phenotypic frailty as a primary measure. perhaps we are missing some of the multidimensional nature of frailty in these patients. So our aim was to create a cumulative deficits frailty index for solid organ transplant candidates. We chose this approach because our hypothesis was that we could use our data from the candidacy assessment to develop this index, and that it may provide a more holistic view of frailty in these patients. The cumulative deficits index can encompass a number of domains, including physical, psychological, and social domains of function. We also wanted to use this index to predict outcomes of the assessment, waitlist, and post-transplant mortality. So we performed a retrospective cohort analysis looking at 815 subjects and collecting 78 clinical variables from their candidacy assessments. We chose consecutive patients from the 2012 to 2013 liver, lung, and heart transplant candidate groups, and from the 2009 to 2010 renal transplant candidate group. We chose a earlier date for the renal transplant candidates because they wait longer for transplantation. 36% of our cohort was female. Our mean age was 53, but the range was broad from 18 to 74. We had 21 combined transplants, such as a kidney pancreas, and these patients were added to the dominant organ group, such as kidney for the kidney pancreas patients, for the analysis. So the cumulative deficits index conceptualizes frailty by counting the number of deficits to arrive at a continuous frailty index. Much of the cumulative deficits literature was developed by the group working with Ken Rockwood. In this literature, this model has demonstrated frailty through the age spectrum and in some chronic medical conditions such as HIV and left ventricular assist device recipients. We took our 78 variables and then looked to see if they fulfilled these criteria for deficits. So they needed to reflect health status, usually increase with age. They could not saturate too early. For example, presbyopia, it saturates approximately by the age of 50, I believe. So it would not help differentiate patients. So we needed to make sure that we didn't include those types of deficits. In addition, we wanted to make sure we included deficits from multiple domains, and that the index in finality could be used for serial measurements. So we scored each variable or deficit between 0 to 1 if it was present. Some variables had partial scores, such as osteopenia, which received a 0.5 compared to the 1 for osteoporosis. And then we looked to see if it fulfilled the criteria listed on the previous slide. Unfortunately, we had to exclude some potential deficits due to incomplete data in this retrospective cohort. To be included in the index, we required at least 85% data completeness for each variable in our cohort. Once we scored the deficits, we totaled each deficit for the patient and then divided it by the total possible deficits for the patient. A frailty index for a patient could not be calculated if they did not have at least 80% of deficits scored. So this busy slide shows our 40 deficits that are included in our frailty index from the 78 variables collected. To make this a little bit easier, I'll show you some examples of deficits. So medical comorbidities were included, such as diabetes or cardiovascular disease. We also included visual and hearing impairment. We looked at functional markers, such as activities of daily living and the requirement for mobility aids, and a number of laboratory markers as well. So once we calculated all our patients' frailty indices, we noted that the mean frailty of our population was 0.29. In a typical normal population or general population, the histogram should show a gamma distribution because the majority of people in the general population are not frail. So the curve will peter off as patients become more frail. In patients with disease or groups with disease, the distribution becomes more normal, as we see here. And this has been also seen with other disease states. Our range of frailty was broad, from 0.06 to 0.6. Frailty did increase in age in our population in the heart, liver, and kidney transplant candidates. But it was an exception in lung transplant candidates. Perhaps this was due to referral bias. Maybe we were missing some older patients with end-stage lung disease that were more frail. Maybe there is a bit more stringent criteria to move toward evaluation. Patients were seen by a consultant first and then required, and then the decision for evaluation was made. Or perhaps older patients declined assessment after hearing about the risks of transplant. Unfortunately, we do not have the data to extrapolate the true reasons. In the lung population, we also have the cystic fibrosis patients, which are typically younger, but removing them from the analysis did not change the fact that lung transplant candidates' frailty did not change with age. So when we look at the process or steps leading towards transplant, we had 815 subjects, but we could only calculate frailty indices for 794 because 21 patients did not have 80% of variables answered. From the 794 patients, 506 or 64% of the population was listed for transplant. Unfortunately, 90 subjects and 48 had medical contraindications, and 48 subjects passed away prior to being able to be listed. So once patients were listed, we had 46% of our 506 of our 794 subjects receiving a transplant. Some patients did improve, but that was only 1% of our population. We had 21 patients with medical contraindications causing delisting, and 69 patients died while on the wait list. From those that were transplanted, 40% of our total population were still alive at the time of censoring. So when we look at frailty, at the time of making our decision for listing or our assessment outcome, we see that frailty does correlate with our outcomes. In this bar graph, increasing frailty is seen with darker colors. As you can see, overall frailty is higher in patients that were not accepted for transplant due to medical contraindications or those that died during the assessment period, which was statistically significant when adjusted for age, sex, and transplant type. Because of the small number of events, we created a composite endpoint to encompass all of the negative outcomes that could occur once listed for transplant. These negative outcomes include waitlist, death, or delisting due to medical contraindication, or death after transplant. Using the composite outcome, we can see that increased frailty is associated with poorer post-transplant survival, waitlist survival, and a higher chance of waitlist delisting. We also divided the composite outcome into its components. As you can see here, for waitlist specific outcomes of death or delisting due to medical contraindication, the highest frailty group was more likely to be delisted or pass away on the waitlist. When looking at our post-transplant group alone, those with a frailty score greater than 0.25 were more likely to die post-transplant than those with lower scores. We then performed a Cox proportional hazards model to evaluate the composite endpoint. In this analysis, you will see the social vulnerability index. So this was a 10 variable index that we created to look at socioeconomic factors that may affect a transplant candidate. Some of these things included active smoking or alcohol misuse, needing an English interpreter, employment status, distance from a transplant center, and the presence of a support person. Higher social vulnerability denotes more socioeconomic challenges. With our univariable analysis, we noted that frailty, age, and socioeconomic factors were associated with the composite endpoint of death and delisting on the transplant waitlist and death post-transplant. The risk of death or delisting is 5% for every 0.01 increase in the frailty index. In the multivariable analysis, age and socioeconomic factors lose its significance, but frailty remains associated with our composite endpoint. And the risk of death and delisting now is 3% for every 0.01 increase in the frailty index. When we looked at discharge disposition after transplant, we noted that frail patients were more likely to need discharge to a rehabilitation facility than patients that were less frail. This is unsurprising, as frail patients tend to be a bit more deconditioned than our non-frail population. So when we look at our project in total, we were able to create a cumulative deficits frailty index using only the data available through a routine multidisciplinary transplant assessment. We have shown that frailty is more common in the solid organ transplant population, and that frailty acts independently of age. When we compare frailty in our population to frailty in the general Canadian population, which was described from the Cumulative Deficits Frailty Index created from the Canadian National Population Health Survey, solid organ transplant candidates are frailer. Our solid organ transplant candidates at the mean age of 53 have the same frailty as 85 to 90-year-olds shown in Dr. Rockwood's paper from CMAG in 2011. We also noted that higher frailty is associated with poorer assessment outcomes, such as death during assessment and medical contraindications to listing. It is also associated with increased waitlist death or delisting and post-transplant mortality. So currently, we are working on a prospective study to evaluate this frailty index in solid organ transplant patients, and also looking at this index compared to the frailty phenotype. In this prospective study, which I'll show you on the next slide, we are also evaluating the change in frailty after being listed and after receiving a transplant. We are also working on measuring frailty in organ donors to see if donor frailty affects recipient outcomes. We also are considering how frailty works with current transplant risk prediction models and to try and assess the utility of using frailty in addition to these models in candidacy decision-making. Although we have found these associations of increased mortality in our cohort and in others, we had some significantly frail subjects that successfully underwent transplant and had survival until our censor date. We think that it is important to decipher how frailty can be added to candidacy decision-making, because in some cases, increased frailty will lead to poor outcomes post-transplant or on the wait list. But there is this population of frail patients that do receive transplant benefit. So ideally, frailty measures will help us discover some of these frail patients that may benefit, as we may be excluding this population due to our clinical gestalt or eyeball test. So our current prospective study, led by Leanne, is FROST. We're comparing the cumulative deficits index with the frailty phenotype, as I mentioned previously, and measuring it throughout the transplant process. We will be looking at survival, quality of life, and other important outcomes to see if these correlate with frailty. And hopefully through this study, we can learn about the transplant process itself and see how frailty changes because of transplantation. Transplant may be an intervention to decrease frailty in many recipients. So I'd like to thank our team from UHN. We had a number of collaborators and co-investigators that were very helpful. I'd also like to thank Drs. Theo and Rockwood from Dalhousie and the Canadian Frailty Network for their support. And thanks for everyone coming to this webinar today. Leanne and I would be happy to answer questions.
Okay, thank you, Ria. And I'm assuming Leanne's still there with you and hasn't been called away?
Yep, I'm still here.
Okay, good. So that was a very informative presentation, and now we'll start our Q&A part of the webinar. So just for everyone to please continue to send in your questions using that question functionality. And also both presenters' email are on the last slide in case someone would like to follow up if we don't get to answer your question before the end of the webinar. So go ahead, Amanda, and you have a few questions already.
Yes, great. Thank you very much. That was a great presentation and really a good example of how frailty isn't exclusively associated with chronological age, how it's often conceived by the lay public. So to start off, I wanted to ask you how frailty should be used in transplant candidacy assessments. So whether or not it should be given maybe a lesser weight than other information collected, or if it should be given equal weight. How do you see that going forward?
I think we're not sure how much weight frailty should be given, and I think there's a population of frail patients that transplant may not actually help, but there's definitely a group of frail patients where transplant may be a wonderful intervention. So I think eventually moving forward, if we can try to sort out which patients we can help versus the ones that we aren't helping, then it's going to be a very important part of our assessment, evaluation, and potentially addition to one of our risk prediction models for outcomes.
Great.
Leanne, I agree with Ria. I just wanted to also say that different ways of measuring frailty might give you different information. So, some of the data on the phenotype model has been kind of contradictory. It may be that it shows a population at higher risk of adverse outcomes after transplant, but also some of the elements of the phenotype approach are also things that are associated with end-stage lung disease, end-stage heart disease, and some of the other conditions that lead to organ transplantation, like slowness and fatigue. And so these are things that we would certainly expect would improve with transplantation, as we found when we sort of tried to look at the phenotype retrospectively, the stuff that Dimitri Rosenberg that Ria showed earlier in her talk, that it might actually identify a group of patients who can derive more benefit from transplant, whereas we're wondering if cumulative deficits, because they're not things that you would necessarily expect to reverse with transplant, may be better at identifying a population of patients who would derive less benefit from transplant. And that's some of the stuff we're looking to test prospectively.
Great. Yeah, no, it's definitely very interesting. And there are so many different frailty assessments. So what you using the sort of more of a cumulative deficits method, what are the disadvantages of using that, you know, compared to a Freed's, like a shorter question, like the phenotypes? Could you, going forward, I know that you're looking at this prospectively, but do you have any hypotheses?
One of my concerns is that the cumulative deficits model may not be able to clearly show improvement in frailty, because some of these deficits that people accumulate are unlikely to go away, such as diabetes or hypertension, especially after transplant with some of our medications. But even though they maintain some of these deficits, they still may be more robust than they were pre-transplant. And I'm not sure how well the cumulative deficits index will be able to show that for us. And the prospective study would be very helpful to demonstrate the ability of the cumulative deficits index to demonstrate it.
Mm-hmm. That's a good point.
Do you have any other thoughts?
I think that there's a broad perception that cumulative deficits indices are more cumbersome because they include so many variables, you know, typically 40 or so, you know, in our thing, but it's always a sort of the 30 to 70 kind of range of number of elements that you need to include. And we've tried to address that here by including data points that are being routinely collected in the transplant assessment anyway, but the transplant assessment is not necessarily standardized from one program to another. So other programs may find this very easy to implement, or they may find that they're not collecting the data they would use. They would need to create this particular index, although, as you know, Ken Rockwood and his group have shown, really it doesn't matter so much what specific indices you include as long as you're broad enough to capture a spectrum of deficits.
Right. That's a good point. And what about, I have another question here, and it's asking, were there any social markers included in those 40 markers that in your frailty index?
So we didn't include social markers such as support people or distance from our transplant center, smoking, alcohol, or recreational drugs in the frailty index, because how they're associated with health status can be relatively variable. And so that's why we use the social vulnerability index as our marker to adjust our analysis. Moving forward, we have other transplant psychosocial assessment indices that are being used more commonly in transplant assessments across North America that would replace our social vulnerability index.
Okay. And you did mention, so there's a frailty assessment may be an important part of the prognostics of who will, you know, do well after the transplantation. And you showed some data, I believe the Rosenberg paper, that looked that about 3 months after transplantation, there were individuals, you know, people improved their frailty status. Is there any information about the interventions post-transplantation that were used, or, you know, whether or not those, is being used is being accelerating, you know, improvements after the surgery or improving outcomes?
So it's very variable depending on transplant program. The paper suggesting improvement in frailty post-transplant of 3 months is by McAdams DeMarco, who was looking at renal transplantation at Johns Hopkins. I'm not quite sure what they do post-transplant, but in most programs, if people need physio or rehab, they are given some physio or rehab. And then there's medication adjustments as well. In the Rosenberg paper, our lung transplant patients undergo 3 months of rehabilitation post-transplant, even after discharge, in addition to regular clinic appointments almost every week if needed to manage their complications and side effects. So from an intervention standpoint, we have physio, we have some nutritional interventions if the patient needs it, but we would be very interested if there were some focal or novel things that we could add to our post-transplant care to improve their frailty.
Okay. And I have another question here. It says, someone is asking could you clarify what the eyeball test is?
It's when you see a patient and you deem them as frail or not frail.
Okay.
Literally, they're just right in front of you. I meant it as a colloquial term.
Okay.
Yeah, there's not really such a thing, but it's very commonly sort of said in surgery that surgeons feel that they can figure out whether a patient's going to do well with surgery or not from the eyeball test, and it's just laying eyeballs on the person to see what your subjective impression is.
Okay, great. I don't have any more questions here, so Carol?
So I don't know, we usually at the end of the webinar ask if there's anything after hearing all the questions that you think that you'd like to share with the audience before we end today's webinar. Or have you said everything?
Yeah, I think we've said everything. But I think it is, as pointed out, I think this is an interesting illustration of how you can think about frailty outside of its usual place in the elderly. And we have another study that we are also from our group that in which we applied a very similar methodology to look at frailty in individuals with cystic fibrosis going for transplantation. These are typically people in their 20s, 30s, and 40s, and we saw very similar high frailty indices in this group of very young patients.
Interesting. Ria, do you have anything to add before we sign off today?
Don't forget that frailty is not just a syndrome of the old. It's a syndrome in everybody.
Yes, you're right. I know we're concentrating on that age group, but yes, we do discuss that quite often at our board meetings. Okay, so I thank you very much for coming on today and taking the time to share your work with everyone. I know that you've left your emails there on the screen. I'm not sure if we have that up right now in case somebody thinks of a question after we sign off. And thank you for everyone who has taken the time to come on today to learn about this. And I'm hoping that everyone will join us at our next webinar on January 23rd. So that ends today's webinar, and hope everyone has a great day. Thanks so much. Bye-bye now.
Thank you.